So very pleased that Dr. Shrikant's able to join us, talking about family physicians training in India, which Scott and I and Jennifer as well have been involved in the development of that. And then Scott's going to talk to us reflections on this new Lancet Commission report, The Value of Death, which probably most people have come across. Just challenging us to think in different ways and to think maybe what is a realistic utopia. I've never heard that expression before. I was thinking it's an oxymoron, but no, we have to aim for what's important, and then yeah, we'll finish off then with just talking a little bit more about the group and where we go on. But I'll stop sharing this now. But we're very pleased that Ednin's agreed to just share a few words about Dr. Cynthia, who we were all shocked to hear had died. And such a lovely lady. I only met her once. I had the privilege at an APHN conference of meeting her there. So thank you, Ednin, for giving your reflections on her life and her contribution. Thank you.
Thanks, Dan. It's quite a sad moment that we have lost Cynthia to our work. Just over a month ago, she passed away on February the 13th, just not long ago, in a home with her family through pancreatic cancer. I don't know how many of you know her, but she's somebody I really know very well. I've worked with her over really about the last 25 years or so, and from really being a mentor to a very close friend. One of the things I felt with her was really as a consummate all-rounder in palliative care. She trained initially as a physician in internal medicine, but she was also a researcher. Not many people would know that she has a PhD in molecular biology. And that gave her a very strong research framework, and it allowed the amalgamation of how she approached her work into the real delicate way of assessing clinical situations into the aspects of rigorous assessment. So you could see the real sort of definition of palliative care come into practice to how she approached her clinical work. She would often question, what's causing this? What's the evidence for this? And I felt that in seeing and working with her through clinical practice, you could see how palliative care principles and practice is being applied really in front of your face. The way that she communicates made everyone felt that she really cared. She understood what your concerns were. And as though she was able to block out all the other distractions that's around the situation. So it was just between her and the patient. I don't think you could find many other mentors that could work like that. The other area which I feel she excelled was in advocacy, and that was where I guess her work in APHN really shone through. She is as adept working in a clinical situation as well as in a meeting room with people. She would work intuitively, instinctively to know who are the people that she needs to connect with that would be able to deliver change in healthcare systems to promote palliative care. It may not be the clinician, it could be a policymaker, it could be the bank manager or someone, but she would instinctively know who it was that she needs to bring together, to talk to deliver change. And she did this everywhere in the region. She was able to see potential in so many people and nurture them. And I guess over the course of the last 30 years or so, she has helped so many people across the region develop their careers. She is an incredibly generous person that if you ever had asked her for any favors, any time, she would grant you that time. She never seemed to sleep. If anyone, if those that you that know her, she doesn't seem that she slept. I was receiving, I miss in a way, maybe I don't miss. I was receiving emails and texts at 3 o'clock in the morning, 4 o'clock in the morning, and that kind of nature. And there's always this sense of, okay, something needs to be done. Do you have time to do something? So it's full of energy to do things. And having taken over the chair of APHN from her, I now realize the amount of work that she was doing. It is incredibly astounding. The capacity building projects that we were doing in Asia Pacific, in Myanmar, in Bangladesh, and Sri Lanka, she led every single mission 3 times a year. So in those countries, that was really, she led every single training visit for all those years. And she had a hand in talking to doctors, nurses, policymakers in those countries. And in a way, that was why the projects have delivered. I guess it's her passing has left a huge void within the region. But from the messages that we have received, there is a very strong movement of those who have worked with her to carry on her work and her legacy. And within this group, I do feel that it is very, very important, because her initial work in palliative care in Singapore was in the community. She worked in the Assisi Home and Hospice, at St. Joseph's Home and Hospice. She helped founded the Singapore Hospice Care Association. So those were all community movements in Singapore before she moved into her work in the hospitals and the National Cancer Center. So she had a very strong link to community and primary care aspects. And I feel that she was certainly very supportive in my initial proposal to form this group. And I do feel that the work of this group is important to carry on that aspects of her work and her legacy. So, thank you so much for allowing me to say a few words about her. I think that she has been an incredible inspiration to myself and to many other people in the region. Thanks, Dan.
Thank you so much, Ednin. And it's really good to hear some more details about someone who was an incredible person in terms of what she achieved, and just the personality that she was. Just where we're quite a small group, so I know that there are others here who knew her well. Don't know if anyone else would like to add anything. I think that would be okay. If not, that's fine. But just to give people space in case they want to have a memory or something. Well, that's great. Oh, Scott.
I could maybe share a memory. I visited her at her home, in fact, and she was so kind, and she took us out for afternoon tea out of the busyness of her hospital ward. She said, come and do this, when we visited her in there. She's such a kind person. And other conferences, she is so good at networking and advocacy. And it's great to hear how she's so supportive of work in the community, how she began that way as well. It's a lovely lady, huh? She's
absolutely.
Thank you, Scott. Yeah. Okay. Well, we obviously want to send our condolences to her family and also to the friends of her on this call, and
I would probably
and also other friends. But
I would probably add, Dan, the family are setting up a legacy project potentially called the Cynthia Goh Global Palliative Care Institute. So that is a work in progress that would be supporting palliative care in the region. Yeah.
Okay. Right. Thank you so much, Ednin, and yes, and we'll hear more about that in due course. Thank you. So I'm delighted to introduce Dr. Shrikant Atreya, who's I think one of the pioneer MDs in palliative medicine in India. I think I met him probably about 9 years ago now, and he's a consultant at the Tata Memorial Centre in Kolkata, and also he's a PhD scholar at the Department of Palliative Medicine in Supportive Care and MAHE in Manipal. And I know he's a prolific author, just had things published, and he's been working very hard on developing the family physicians program in India. And so I thought a number of people said it would be helpful to have some discussions around education, particularly. So Shrikant has very kindly agreed just to speak for a few minutes about the Indian project, and maybe then we can have a discussion and ask him questions about that. So thank you. Over to you, Dr. Shrikant.
Thank you, Dr. Dan, for your kind introduction. And this has been a work which has been almost for 5 years now. And this work is Dr. Dan, Dr. Scott, Dr. Alan, Dr. Jennifer. It is basically our baby. Basically, we've been working on this since then. And it's been a real hard work that each of us have put in. And we are somewhere there. I guess we are at least somewhere. We have achieved the target of going on educating the primary care physicians. I'll share my screen. Is the screen visible? Yeah.
Yes.
Yeah. So today we are going to be talking about our work, which is on what we did in the last couple of years in developing the education program for family physicians in primary palliative care. And before I begin the presentation, this is a huge list of contributors, faculties, I would say, who have volunteered and who have done a prolific work in getting this done, because their inputs, their views, their participation in this project has come up where we are today. And specifically, I would like to thank Dr. Jennifer, who's here in our group, Dr. Dan, Dr. Scott, Dr. Alan Bernard, Dr. Raman Kumar, Dr. Mary Ann, because these are the people who really kind of spearheaded the entire program. And today we are somewhere successful in getting this integrated into the family physician curriculum with the national board. I'll discuss about this in a little while later. So just a problem statement as to why we felt this was important, and this is known across the globe. It's not that something which is unique about India, but India has its unique features where we think that primary palliative care is of essence, because we know that across the globe, there is a rise in the trend in both non-communicable and communicable disease. But India is unique because as high as 63% of mortality and associated DALYs are related to non-communicable diseases. And communicable diseases, although we are seeing a downward trend, is still causing a lot of morbidities and mortalities in patients in the community, especially very high in the rural areas, which comprises more than 75% of the population. And we have a very unique position because it's not just a disease, it's not just about the prevalence, the mortality and the morbidity, but also this is further compounded by the vulnerability to poverty, and most health expenditure is out of pocket. And because of this out of pocket expenditure, large proportion of the population, especially in the rural and the tribal areas, do not access healthcare at the right time. So most patients get detected at a very late stage, and where they would benefit a lot from palliative care, which again is a dismal state, because although all and most of these patients would benefit from palliative care in the country, in India, only 0.4% of the population has access to it. So with this, I met with Dr. Mary Ann Mukherjee was my professor in Tata Memorial Hospital, where I underwent training in palliative medicine. She and I spoke one day that we need to do something about developing the primary palliative care model. And that's when Madam said that you need to speak to Dr. Jennifer. She's in CMC Vellore. And I contacted Dr. Jennifer, and it was so beautiful, really, Madam, not because you're there in the group that I'm saying this, but it was really a fantastic experience, because I just spoke to Madam Dr. Jennifer, and she said, yes, we should do something about it. And it was so encouraging. I felt that, yes, we are there where we are today. So I really thank Dr. Jennifer for encouraging me to get into this a lot more. So how did it start it all started in 2017. In 2016, December, I spoke to Dr. Jennifer. Then Dr. Jennifer said, why don't we start something, contact people and get in more and more people. So in January 2017, there was a commencement of the Primary Palliative Care Task Force. So it's a nutshell of what we have done so far in brief, and then I'll go on to the details of it a little later. So in 2017, January, we started off the Primary Palliative Care Task Force. The members of the task force were many national and international faculties. It is just not the national, but there were a lot of international faculties like Dr. Scott, Dr. Dan, Dr. Elizabeth, Dr. Moira, who were also part of this venture. So annual discussion to discuss the role of family physicians in community-based palliative care. And this presentation was the first presentation which we did in 2017 at the National Conference of the Association of Family Physicians of India. In February 2017 of the same year, we were given the opportunity by the President, Dr. Marianne Mukherjee of IAPC, to present our work and the way forward in how we would like to collaborate with IAPC and AFPI and learn how to collaborate. So basically, the collaboration began from February 2017. In the year March 2018, we wrote the first position paper, and it was published in the Journal of Family Medicine and Primary Care, thanks to Dr. Raman Kumar, who is the president of AFPI, who has been with us since our journey began. In 2019, the task force, the members of the task force wrote up the Competency Framework for Primary Palliative Care. It was published in the Journal of Family Medicine and Primary Care. So in 2019 and 2019 to 21, despite the COVID, a lot of people have really been putting in their heads in their efforts, despite the busy schedule with COVID. And we prepared the training modules for primary palliative care. It was reviewed, vetted out by all the faculties, and then submitted to the National Board of Examination, because National Board of Examination is an examining body for the family medicine postgraduate curriculum. Then the modules were then in 2021-22, we were lucky to have this module incorporated into the National Board of Examination. And also, interestingly, the task force members have been empaneled as faculties who would be teaching palliative care, primary palliative care, to the family physicians who will be graduating from the National Board of Examinations. So this has been our achievement thus far in a nutshell. So what did we do? So what was the reason for the task force we formed, and what happened is what I'll be discussing now. The task force for developing the primary palliative care was convened at the IAPCon 2017 in Coimbatore. The goals were to decentralize palliative care into the community, basically more into the community with empowering the community-based palliative care program, capacity building of the general practitioners, family physicians through training dissemination, empowering family physicians and general practitioners into providing a collaborative primary palliative care between the specialist and general practitioners. As I mentioned, the task force members were a very variable faculty. It included faculty, national and international faculties. And interestingly, it had faculties from palliative medicine, family medicines, distance education, public health, and geriatric medicine. The task force discussed on what were the then or existing lacunae in healthcare provision in palliative care, and chalked out a plan to develop a primary palliative care module to empower the general practitioners. And that's when the plan was made to write up the first position paper for developing the primary palliative care and the need for it. The position paper was published in 2018, as I mentioned earlier. This is the first formal liaison between the Indian Association of Palliative Care and Association of Family Physicians of India. The position paper was published with the aim to support integration, network, and collaboration between palliative care specialists and family physicians, general practitioners. The paper focused on purely the Indian context, the need for education and training in the core competencies appropriate for providing primary palliative care, recommendations for primary palliative care dissemination by the task force members. What were the recommendations of the task force members as was highlighted in the fourth position paper? It was based on three premises. One was service development, education, research, and audit. Service development, as we mentioned it earlier, we were looking at a collaborative and integrated work where specialists and primary care physicians or the general physicians to work hand in hand during the program. General practitioners, as we know, would act as fulcrum in the care coordination. They developed a standard operating procedures for delineating roles and responsibilities. The position paper also mentioned about referral pathways and SOPs for referral and collaboration, documentation at follow-up and cross-referrals. It also mentioned about the need for availability of essential drugs before the starting of the program. And of course, regular meetings that follow up at the national and state level to see the progress, to check the progress of the program. Education, as I mentioned, the education also mentioned about to start off with the core competencies represent essential knowledge, skills, attitudes, and values that a primary care physician would need while delivering good palliative care to the community. Clearly defined syllabus and a blended modality of training general physicians, especially general practitioners being extremely busy. We had to look at a program that would be blended program, both online and offline. Most importantly, to gain accreditation by the IAPC, AFPI bodies, which has been, now we have achieved that, and also incorporation into the National Board of Examination and the National Medical Council. Research and audit, regular audits by the IAPC, AFPI body of the progress that we envision to do in the near future. Research to ensure quality, evidence-based practice dissemination, and a collaborative research between the Indian Association of Palliative Care and Association of Family Physicians of India for promoting primary palliative care. In 2019, we then published the core competencies for developing the primary palliative care module. The main goal was, as I mentioned earlier, for primary care or a family physician to be able to provide primary palliative care in the community using standardized protocols. Effectively identify the primary care physicians should be able to identify patients with palliative care needs. The competency framework also mentioned about enabling family physicians and general practitioners to alleviate suffering and improve quality of life of patients, and also timely referral to specialists when needed. And to affirm continuity of care to ensure that every patient is provided care at the place of care they prefer. This is in short about what the module comprised. So there's nothing, just mentioning about the competency framework basically comprised modules such as physical identification of patients with palliative care needs, physical symptoms of pain and other physical symptoms like nausea, vomiting. It spoke about psychological and spiritual care, ethical and legal aspects, bereavement care and family support, teamwork and leadership, and local data on palliative care as a starting point, and communication and breaking barriers. These are some of the modules which we had prepared, and we'll be evolving it. We've already prepared, and the modules are ready, reviewed, and vetted out by the faculties. Then in 2019-2021, training modules of primary palliative care were prepared, reviewed, and finalized for publication, and was sent to the National Board of Examinations for integrating or incorporating it into the family medicine curriculum. In 2021-2022, the modules were incorporated into the National Board of Examinations for family medicine. The national and international members of the task force were empaneled as faculties who will be now teaching family medicine physicians by primary palliative care. And recently, the training module has been also will be used by the University of Makerere, Uganda, for training family physicians in Uganda, thanks to Dr. Moira. IAPC AFPI joint venture will be venturing into blended training programs, and that is in the pipeline. So we have been discussing between AFPI and IAPC presidents, we've been discussing about how we could start off this blended training programs, and we still are not sure about how many weeks, how many months. We're still kind of working out the modes of training. This is still in the pipeline of developing an app, because especially general physicians are extremely busy. So for having them to share cases with us in the community, so we are planning to prepare an app, a virtual interactive app for service and feedback dissemination and for training, where they could virtually interact with us, maybe discuss cases with us through training modalities, through use of app. So this is the last slide. I would like to acknowledge that, thank all the members of the task force I mentioned earlier in the first slide, because without their active engagement, involvement, and encouragement, we would not have seen this day at all. Dr. Raman Kumar, who's also a member of our task force, who's been actively involved and been promoting and advocating palliative care in family physician curriculum. Dr. Marianne Mukkardan, who was the ex-president of IAPC, Indian Association of Palliative Care. She is the one who encouraged me to start off this primary palliative care program. And Dr. Sushma Bhatnagar, who is the present president of IAPC, who is now helping us work on the collaboration between AFP and IAPC to develop the primary palliative care module. Thank you, everyone. Thank you. Happy to take questions.
So much, Dr. Shrikant, for that very interesting presentation, and just it's amazing what's been achieved. We haven't had any questions coming up in the chat yet. Doesn't matter, you can put your hand up as well to ask a question, or just unmute. But while people are thinking, can I just ask how one of the things that has impressed me the most is the way that you've moved forward to get accreditation so quickly, really. I think these things are very difficult. We're the champions and the people who are really keen to see these things develop. Was it quite a complex and difficult process to get it accredited and incorporated into the national exam, or who led that process? How did it work?
So I would actually, it's a commendable job of Dr. Raman Kumar. So Dr. Raman Kumar is the president of Association of Family Physicians of India, and very opportunistically is also the member of the DNB board. So that really helped us a lot, and his active engagement and involvement with us, and most of our papers got published because of him, his active engagement with us, and also because of his active engagement with the national board with us. And the only one line he said that, Shrikant, just tell me what you want to do and we shall go that way. So he was very encouraging, and he was very promotive of the fact that we need to have palliative care ingrained into family medicine curriculum. And he's the sole person who got this done with the National Board of Examination. So accreditation, though it took a lot of time because of COVID, but he ensured that it got done. So yeah.
Great, excellent. Thank you. Yeah, and it just goes to show how having these champions is so important. As Ednin was saying, Dr. Cynthia was particularly skilled at that, and actually it's good to find who these people are who are able to have these links and be able to promote the sort of collaboration and the incorporation into formal training. So Dr. Maria's given us a question here. How long is the program? Is it recognized as specialist? How to learn more about this program? Didn't see any social and spiritual aspects on the module. Could you explain more? So quite a few questions there, but I'm sure these are things that others are also interested in.
So I can share the synopsis where we had mentioned about the duration of time for each module. But what we proposed doing was a 6 weeks training program. So we're still in the pipeline as to how to disseminate. But what we intended doing was having a blended training program wherein we would have 6 weeks, wherein maybe 1 or 2 weeks of physical training or online training, wherein the students would be given more of a theoretical training, and maybe 4 weeks or 6 weeks of hands-on, wherein they could be posted to each of the centers where the palliative medicine units are. So that's what we intended doing. And since these are family medicine DNB postgraduate students, so we thought that 1.5 months would be a good timeline for us to kind of train them. And if they were interested for further training, they could always enroll for formal postdoctoral, post-DNB fellowship programs with either of the institutes like CMC Vellore with Dr. Jennifer and with me, or with any of the centers that have palliative care programs running. And I'm happy to share the synopsis with you. Of course, because it mentions about the duration. Each module, we have timed it out as 45 minutes of theoretical training. And like, for example, we took at communication and breaking bad news. We said that that's the most important module. So we're giving 60 minutes for the training module, wherein we'll be not only doing theoretical part of it, but also hands-on, wherein we'll be doing role plays. And that's how we expect students to learn. Yeah. But I'm happy to share the synopsis, which mentions everything in detail. Yeah.
Yeah, no, that's great.
I'm sorry, did I miss any question?
I think Marie's also asking if you could share the papers that you mentioned, and I think that would be great if maybe Tanen could circulate those to the group,
Sure.
and so that everyone can get to see there. I think Jennifer's put a comment there about there is a module on psychosocial and spiritual care. I think that was listed there. So
yeah,
no, that's great. Jennifer, is there anything you want to add, because you were sort of very much involved with the with how things were put together?
Thank you, Dan, for the opportunity, and thank you, Dr. Shrikant, for taking it forward. So yes, I think what really helped was getting the right group and people who can advocate and take it to the official bodies, because again, getting something into the national board, DNB board, is not very easy. So having the right people, getting them involved and making them see the cause, and we were fortunate to have somebody who valued primary palliative care. So I think that was a great asset. The COVID has certainly played down the pace in which we would have otherwise liked it to go. And we are hoping to develop these educational programs. Again, this is not just for those who have done family medicine, but also for those, not the ones who are only doing, those who have already done and would like to upskill themselves in primary palliative care will also can also access this. The challenge, I think, again, being a blended program, challenge will be how much of contact or an observership will be feasible for many, because I think the challenge comes with time and commitment to work. So that I think will be a challenge for many, and we need to think carefully when we design that. Thank you.
Okay, thanks, Jennifer. A couple more questions. One from Tanya Pastrana about evaluation. Is that planned to be happening? And then the other questions about certification and issues with palliative care specialists. Right, okay. I may be feeling a bit threatened that I might get outnumbered by skilled GPs in palliative medicine. So a couple of questions. Do you want to address those, Dr. Shrikant? That would be great.
Yeah, so I'll start with the accreditation. So as I mentioned earlier, the president of IPC and president of AFPI, Dr. Raman Kumar, is actively engaged with us, are more than happy to give the accreditation and certification from both. So we would be starting off with trainings that will they will get accreditation from the IPC AFPI collaborative body. And the second accreditation, as you mentioned, that the TNB board has approved palliative care as one of the integral modules for family medicine. So that's one of the other areas where we'll have primary care physicians, family physicians coming out with this skill set to be able to provide primary palliative care in the community.
Okay, thank you. Sorry,
I forget that we have just started off, so I guess we'll definitely have some evaluation and feedback. Jennifer, you want to add something with regards? Hello.
Hello. Sorry. Yes, you were breaking up a little bit. Oh, are you still there? Have we lost Dr. Shrikant? Oh, Jennifer, do you?
No, he's there. He's muted and.
Sorry, I got logged out. I'm so sorry. I'm so sorry.
Yeah.
Oh, okay, great. I'm glad you're back.
Yeah, I'm sorry. I got logged out in
Dr. Shrikant, if you have your video off, maybe your audio would be better.
Yeah. So regarding evaluation, so we are still working on that. So yeah. Okay. So with regards, now am I audible?
Yes.
Okay. So with regards to evaluation, we are still in the pipeline. We haven't yet thought about it, definitely, because we will be, that's an important and integral part of it. And we are taking one step at a time, and definitely we would have some evaluation, and especially from the DNB board, we'll have an examination. We do intend that having some form of evaluation before we certify family physicians to be able to get the certificate that they are accredited with AFPI IPC. So, Dr. Jennifer, you would like to add something with regards to that?
No, not really, Dr. Shrikant. Thank you.
Okay. So a question from Sylvia there about how palliative care is integrated into the day-to-day work of family medicine, and whether family physicians have the support of to practice their skills after completing training. I'm not sure, is that something that you're able to, was the thing still quite at a new stage? It's difficult to say for sure.
So at my personal front, I'm not sure, because what we're planning to do as an, I would like to explain this, because we do a lot of interaction with the family physicians in the community, because a lot of our patients who come from faraway places, we do connect with family physicians and try to kind of follow up with them. So what we intend doing is post-training, we are now starting a virtual app. We are just piloting out the app, and we are starting a virtual app wherein we can interact with family physicians in the community. They can post cases to us, we can post cases to them, and we can have an interactive discussion with the family physicians. So that's how we intend following up on the care. I would, of course, admit here that it's still in the pipeline. We have just started off with, we do interact on telephonically we interact with them, but this virtual app-based system is still in the pipeline, and we are still working out our mechanism to get that done.
You. And can you address the question from Teguh from Indonesia, who's actually in Edinburgh now, about how to convince the family medicine college to include palliative care? Any advice? I think you've already said that Dr. Raman Kumar was incredibly enthusiastic about this and has been helping to spearhead. Any other comments on that?
Yeah, so as Dr. Jennifer also mentioned, it's about having the right person on the team. So Dr. Raman Kumar has actively engaged, and family, interestingly, So what we're doing is we are having this annual conferences that that the family physician conducts, and we interact with the family physicians, and we do have, and Dr. Raman Kumar ensures that we have a presentation with them, wherein we have short sessions with the family physicians, kind of advocating for palliative care. And many have expressed interest, and they have actually come up and did mention to us that they would like to undergo some form of training in palliative care, and they feel that as family physicians, that's an important, training that they feel they lack. So
yeah. Okay, that's really great. Thank you so much, Dr. Shrikant, for a clear presentation, and it's obviously raising lots of discussion, which is great. That's what we want in this group, and it's great to see actually that going across countries, and how we can support each other in this way. I'd just like to add it's great to see that the curriculum has been shared and the resources have been shared with Uganda. I was actually teaching yesterday the family medicine doctors in Uganda on Zoom. It's great we can do all these things, isn't it, across the world. And just what really struck me was actually just how enthusiastic they were. And I think actually in general, you'll find family physicians, once they start to learn about palliative care, will realize that it's actually such a great thing to actually be able to do. Often they've come, we all remember dealing with people who've got advanced illness, complex psychosocial issues, problems with symptoms, family issues, approaching the end of life, and how challenging that is. And I think for family physicians to know that they're able to get help in this way, I think can really switch the light on for them. So thanks for sharing that. Thinking it would be great to have these resources on a website when we get our own website set up, or web page set up. That'll be great to have these sort of resources that we can share across the region. So I'm going to hand over to Dr. Scott now. So thank you, Dr. Shrikant, again. And Professor Scott, sorry, is going to talk to us about the Lancet Commission. I've been told we have 15 minutes left. I don't know whether that means this ends after 15 minutes or we can go over time a little bit. Hopefully we don't all get cut off, but anyway, over to you, Scott.
Thank you very much. It's great to come to this group of enthusiasts about primary palliative care. If we have only 15 minutes, have we only got that, then I'll be shorter than that, so there is time for discussion. Or can we go a little longer? Can the secretary tell us?
Yeah, we can go over time. It's okay, but probably not too long, because other people might have other commitments.
Yes, no, I understand that.
Okay, so maybe should I finish by 12 then? By within 10 minutes then? Is that enough? Yeah.
Take as long as you need.
Okay, well, it's good to see such a keen group, and well done, Shrikant. It's tremendous what you've done, how you've done. I also was out in Uganda last week by Zoom with speaking there, and that was to the family doctors there, and it was very cunning because Moira actually had invited to that Zoom, that teaching session, the head of palliative medicine at Makerere University, and she's already very much in touch with the professor of primary care there. So she used that teaching process as a way to advocate also. And my other thought was, how do you integrate the palliative care in primary care, as the question was there? And we were just saying at that conference, well, as a GP, we are interested in helping people with what they come with, but also health promotion. And palliative care is actually part of health promotion. So we should try to find a little time after quickly dealing with the presenting complaint to move on to try to help them if that's possible. But it would be great if the secretary could share the screen, my presentation, because I'd really like to explain a little about this Lancet Commission that was started recently. So if we can make that, can you make that full screen? That's great. So the Lancet had a report recently on a commission on the value of death, bringing back death to life. Now they started a commission on the value of death, and Richard Smith, previous editor, had done this, and I heard a lot about it. And I thought, this is great. And there was no one from primary care at all involved in this, whereas family medicine do deal with death. So I complain quite a bit. And I complained showing them papers and stuff. And in the end, they accepted they need a token primary care person. And I was adopted and I've joined in. I wasn't a commissioner, but I'm on this list because I helped write it, if you want. It's a very dense thing, but it's a great project, I think. Libby Salno, who has done some considerable work in India, as we know, and knows very much about Kerala models, in the end wrote it largely, and Raj Gopal is very much drafted into it as well. And so there's a group of people there, and it's a tremendous way of thinking how we could advance to help people very broadly, not just palliative care, but a wider aspect of how we can help people live and die well and grieve well. Next slide, please. And so I would like us just to spend 6 minutes, if we may, looking at a video called A Realistic Utopia. Now, this slide you're seeing here now is free access, and as is the whole document. It is a free access document. But if we were to click, if we could go to the YouTube video, and this will actually talk about a realistic utopia. Now, that is a bit funny, but the idea, what would be the best scenario we could have to help people live and die well in India, in a part of India, or wherever we're at, but how can it, something that's realistic. So it's a vision that is grounded in reality. And I just want to look at what that might look like. So be thinking of what it might be in your country. So if we could take time just to look at that video, because it's got subtitles, so I think it's good. And if you have actually read this, please just go into chat and say, I've read it, because I'd be interested to find out how many people have looked at the commission already. Just take a moment and do that just as we start. So if we could show the video, that would be great, please. Thank you. Just waiting for it to come, I hope, just now. Yeah. Because what it starts to explain is about the death system, which is, what happens. So we'll make this
what
large.
happens after you die is changing.
This is it. Thank you.
You could become a firework, or even have your ashes scattered in space. You could choose to come back to nature with a woodland burial. Maybe you know what you want after you die, but how about before then? Death and dying are much more complicated.
These are issues that are going to affect all of us, and at the moment, the way we're dealing with them is leading to increased suffering. People are having treatments they don't wish to have, families are not involved, conversations are had too late, people are not getting pain relief, people are dying alone. These are real urgent issues that are happening now.
When we talk about caring for people who are dying, this is more about life rather than about that one moment of actual death. We'll say wise things like we'll cross the bridge when we come to it. But this is not an easy bridge to cross.
Dying in the 21st century is a story of paradox. Some of us are overtreated in hospitals as family and community are pushed to the margins. Others are left to face death all alone.
Most discussions are centered around high-income countries. The suffering in low and low middle-income countries is simply invisible. It's tough even for me. Her whole body is in pain. We now can do better.
In Kerala, India, state reforms alongside engagement with families and thousands of volunteers is pioneering a model of compassionate communities, changing how people live and die.
She says, sit down. She's saying she's much better. This is Lata Kumari, whom we saw last evening. Looks so amazingly and so happily different.
It was kind of everything I hoped I would find somewhere, and it was amazing actually finding it, because they really were creating this whole new model of care, changing the way people cared, the way people died, the way people thought about death and dying.
Across the world, groups are challenging norms and rules about caring for people at the end of life, and bold new models of compassionate community action are emerging.
What inspires me is knowing it can go right. It doesn't happen by accident. But when I see it happening in living rooms, in bedrooms, in care homes, in hospitals all around the world, it's really inspiring. Because although it doesn't take away the sadness and the loss that is so significant, it does take away the stress, the anxiety, the fear that so often just compounds these times.
Allowing the community to come in means training them, answering all their questions, and sometimes being questioned. It means giving up some of my power as a doctor, engage them as partners.
The Lancet Commission on the Value of Death convened experts in health and social care, philosophy, economics, and theology, working with community activists to set out the principles of a realistic utopia, a new vision of how death and dying should be.
What we're talking about in the Commission is whole systems change. It interfaces with healthcare systems, with the law, with policy, with education. All of those, death and dying, are social issues. And at the moment, we're trying to solve them with a medical lens. And that's what needs to change.
We need to talk about what we want for ourselves when we die, and what choices we want for society.
If we want vaccination done across the country, we have a vaccination drive. Maybe we need to have conversation drives in every country. If we talk about this openly, confront the issue, we will be able to avoid a lot of needless suffering, needless treatment. I have prepared my advance directive. I have indicated that in the context of an incurable illness, I should not be subjected to inappropriate life-prolonging treatment, partly because that will only be suffering for me, partly because I will be isolated and separate from my family, but also because out of loyalty to me, my family may destroy themselves with that needless treatment. That's a precious time when I should have been receiving a kiss on my cheek from my grandchild. It can be a time of healing also.
We can learn lessons about death from many different cultures, and from the innovators who are showing us new possibilities for the future of death and dying.
You only get one chance to do this. I heard a lot of people say, I wish I knew what they would have wanted. The conversation ahead of time is actually something you can give to those around you, and the gift that they can give back to you. Death it's not just a physiological event, an endpoint, it's so much more than that.
The realistic utopia starts with each of us facing this, bringing life back to death. It's about leaving a legacy, talking about those we miss, and finding a way through all the sadness to show up for those whose time is short.
Let me clarify that we were not really talking only about death. We were talking about life. What holds meaning in your life for you?
That's great. I've just got a few slides to finish with. If we could have them up, then please, that would be great. So that film actually talked about a death system. That's a funny vocabulary, but the death system includes palliative care, but it does include much more than that. So I wonder about this death system. Next slide, please. Now, these provide means for death and dying to be understood regularly. It's a very broad thing. I'll let you read that briefly. Determine where and how people die, and they encompass many components and places, and they have many functions, and they're very complex. The background message is they're very complex systems and very wide. Next slide, please. The next slide shows actually, this is a mapping out a dynamic, what happens when someone is dying, all the links and the complexities and the different aspects, not just physical, psychological, social, but existential, spiritual, the whole lot. And it's a very complicated, it's a wicked system, we say. We're one small part of it. Next slide, please. So we have to realize that, and I'm now just going to try to explain this idea of a realistic utopia. So what we're saying, we need a radically different vision of future society. And the word vocabulary was used by John Rawls before, but it's a reasonable dream, basically. What would it really look for your country, region, whatever, for people to live and die and grieve well? And it's a radical type innovation. It's the type of things we're doing. So how could we as primary care leaders, try to be involved in this? Next slide, please. And so there are 5 bits. So last 5 slides. Our realistic utopia needs, first of all, we would say the social determinants of death, grieving, and grieving are tackled. So the last Lancet Commission on lack of opioids, obviously we need equity in opioids. So that talks about national equities, inequities, they must be addressed. We must address inequalities by diseases. Why do cancer people? Inequalities by time. So we have to look at all these social determinants, male, gender, bias, all these old public health aspects. We have to get that right. That's a bit obvious. And surely primary care is needed for access. So immediately we're thinking of that there. Next, please. The second aspect of a realistic utopia is we have to understand that dying is a relational and spiritual process rather than just a physiological or physical event. And we're knowing that these 4 dimensions that we talk about are part, but that's all done within a relationship. And again, primary care is set up with, often we would hope, with people who we know before they, if you want, start in the dying phase. And primary care was started 50 years ago, about the same time as palliative care as a specialty. And we both pride ourselves in being holistic, looking at all dimensions. So there's another aspect that we could help if we're thinking of the palliative care provision really well. So it's inequalities, it's about being holistic. Next, the third bit, what do you think that might be about? These are the tenets that wise people think. It's all about networks of care, and they lead and support for people who are dying. So this would include professional networks, the multidisciplinary team, but must be much broader than that. And we know about Kerala models or volunteer setups. And Libby Selnow, in fact, she came and did a PhD with me in Edinburgh, and she's looking at how we can make that apply actually in a hospice and other areas in London just now. How can we actually bring, because there was just about a fight between hospice volunteers and the actual community volunteers themselves. So it's all about networks, isn't it? There's never just one carer, there's a group of carers and much broader. What do you think the fourth thing we could use as a structure? Next slide, please. Conversations and stories about everyday death, dying, and grief must become more common. So whether it's in the Indian Times or TV or films, we want to get death and dying out in the country. In the UK, we have a television program called Strictly Come Dancing. We must have Strictly Come Dying, a television program or something in the media where people actually, it could be educational, and it could actually, people could understand about it. So we need to bring death back into life. And the final thing that the Commission suggests, that death itself can be recognized as having a value in itself, not just a utilitarian value of, well, people die when they can't do anything else, but death allows birth, growth, and change. Because if there weren't a death, the civilization would be unsustainable. We have to die to let other people continue on to grow and to change. And the face of death, facing up to death, helps us focus on relationships and compassion and live better. So we would say, actually, within this document, we actually make a case that there's a value, a positive value of death, which can bring us, of course, because most great systems believe we're going somewhere better. So there's that aspect as well. So death itself has a value. So this book, this commission, is a paper in the Lancet, but it's about 42 pages long, and it's got lots of diamonds in it, lots of phrases in it. I read it and reread it again. It's a great thing to possibly do. Final slide, I think. Next slide is about what, and there are recommendations, a page or two about them. The relationships stem from the structure, the framework we think that things can be looked at by. It's all about relationships. Outcome measures are important, but the process, the quality of the process, that's really what many people measure as well. Partnership approach is important. It's not just health services, nor communities, it's folk together. And this idea of death literacy, allowing people, death education, you could call it, people could talk about it, face up to it. In community, we should learn about it even before we got a bad illness, so we can embrace it. Right, and final slide, please. I think I put one at the very end. Yeah, so can there be a realistic utopia in your region? What might it look like in general? Might these 5 aspects help to shape a vision and a radical transformation in a country? So could you use this as a network of what can we, either generally or as primary care people, how could we attack inequalities, use these as a structure of developing? And the potential of primary care to help transform in these aspects. And how, in fact, can this group of enthusiasts come together? Would they do something to actually work out how might we be able to translate this? And this is actually a once-in-a-lifetime resource we have got just now. I realized that just now. And my last slide here, the dialects, some people know what they are. The dialects can't go upstairs. So we have to transform, otherwise they'd never reign the world. And the final thing, there's 3 last slide, there's 3 last slides. There's more resources there, which are very helpful if you're advocating. And you can use these, they're free, just download them from the site. That's what I did there. But there's things like this. This shows the over-medicalizing, and the pink is primary care incidences. It's really important, but they're not funded. Next slide, please. And I'm just saying there's lots of resources in this that we can use. These are the old trajectories. Is a concept I've been trying to get into. The idea that dying isn't sudden. We have to go early palliative care, and it may value it, and it's all different for different illnesses. Next slide, please. And there's a list of levers of how to change systems. So if you haven't read it, dig into this. It's a great opportunity to work out what we really should be doing or to get around. And it could be done at lots of different levels, but I would suggest that this is a great resource that is free. So I just wanted to flag it up for you, and I better finish there, but you can see it's well worth looking at if you haven't looked at it.
Thank you, Scott, so much. Can we just go back a few slides to the questions that Scott puts on for us? There we go. That was it with the Daleks. So I don't know whether people in this part of the world know what Daleks are, but anyway, from Doctor Who. Just some
Daleks
things just
to conquer the world that they couldn't get up.
To think about. Mm-hmm. Any comments from anybody? Any thoughts around this? I think what I'm so pleased that they had Dr. Raj Gopal introducing that, and he said to start with, this isn't, a lot of these discussions in, say, the Lancet is all about what happens in Western countries, but clearly culturally, socially, spiritually, things are so different in other parts of the world. So actually, how do they map across as well? I think that's really really important. So I'd be very interested to hear what people might say, and it's maybe something we can carry on discussing on the WhatsApp group. When people have thoughts and ideas, we can send messages to each other. So maybe we'll copy those questions onto the WhatsApp group, and then we can continue the discussion after the meeting. And actually, that reminds me, if you aren't a member of the WhatsApp group and would like to be, please send me an email with your WhatsApp number on. I've just put my email in the chat for you there. So anyway, thank you so much, Scott. Any comments that we have in the last few minutes here, or questions, or
Dan, Scott, thanks very much. I think it's a very important paper. I think it's about 40 pages long, I think, when I read it, and I think it raises a lot of questions. My own reflection on it is really the role of palliative care, and that is regards to both the community and the hospital. I think the community and primary palliative care can play a significant role in developing, yes, the so-called death utopia for the region. My one aspect that I sometimes struggle with is our colleagues in hospital and their own difficulty in challenging the hospital system and how death is viewed in the hospital. And I feel that's an area which does need to be looked at further. Sometimes I feel that both from the community and hospital side, they're not always aligned together. And sometimes I wonder that sometimes palliative care doesn't always help in some of the discussions in the hospital setting. And I think that the primary care is where things can improve significantly. The only other area that I want to highlight is the portrayal of death in the media. Often the use of the battle analogy is often used. He lost his battle with cancer and things like that. He failed certain treatments. Those are the typical things that often are portrayed in the media when someone dies. And this has certainly been shown in terms of research that this is not very helpful in dealing with the experience of dying. And I'm just wondering that certainly working with media groups could help to inform further the community at large a little bit more. And one of the things I'm thinking of is to highlight this paper to media groups in order to educate them to promote a better portrayal, a more healthy understanding of death through media.
Thanks for that, Ednin. One other thing the paper does, it talks a lot about the over-medicalizing of death. And if hospitals see that, and it produces very good evidence about this, you know that in the last year of life is huge expenses. And in various systems where there's free access to healthcare nationally, you can see how that is skewed. Things are skewed even more there. So talking about looking at decreasing unhelpful admissions and use of hospitals is a way in where hospitals are struggling, you know, internationally with emergency centres and stuff, COVID. So there's lots of bits of it that actually can be very useful for advocacy and plucked out depending who we're with, of course. But you're right with those two. Mm-hmm.
Yeah, just have a quick reflection that because in Taiwan we have the universal health insurance scheme that cover all the expenditures of healthcare, but once this global budget growing each year, the proportion in so-called medicalizations or in intensive care getting much higher than the palliative care growing. Yeah, so I reflected that although the quality of death and dying's rating has been published, a new version, and Taiwan seems that getting in higher rank, but I totally reflect that this kind of over medicalizations and also this kind of death, the value of death has been not disseminated or well discussed in our society, along with this kind of quality of death and dying. Actually, it's the quality of palliative care provision, not really a quality of death and dying score in each country, and that I want to share my opinions. Thanks.
Yeah.
you so much.
Because I love to think palliative care is increasing, and we have these obliques and you know, but if the same people, while they are getting that, are getting even more and more of lots and lots of other treatment, as is actually happening even in some parts of India, we hear, you know, we've missed the point in some ways. Thank you for your comments.
For those comments, Dr. Pingjen. Any further comments? I think just a couple more minutes, and then we'll have to close. I think it is a very complex, and I love that slide that you showed of the of all the interacting things. You can't even really do it justice in such a complex slide. This is a complex adaptive system, and there's so many things involved, you know, as I say, legally, spiritually, religion, sort of culture, health. This isn't the domain of just health, and actually we need to learn how to talk to people in other you know, in other parts of life as well, and to share with them. So I'd love to hear a lot more from people in different cultural settings, how this actually maps out, and how death literacy relates to health literacy. And so I think there's lots of interesting things there. But do join the WhatsApp group if you want to continue having those discussions. We won't talk any more about the future of the group or the suggestion of doing a survey just now. We can discuss that in the WhatsApp group. I'm sorry things have been a bit slow getting off the ground in terms of the organisation. I blame COVID still, but hopefully in the next few weeks we can sort ourselves out. I just want to mention something that's happening tomorrow, which is, I think I've got it on a slide somewhere. It's the EAPC, primary palliative care group, have got a webinar, a free webinar that we can all join, and Scott's going to be co-chairing that with our very own Dr. Chamath from Sri Lanka, who unfortunately can't be with us because he's just flown into the United Kingdom. But here we go. I think I can share this. It's going to be quite late for people in further east because it's not until the afternoon in Central Europe. Can you see that? EAPC reference group on primary care. I'll put the URL into the chat box as well, so that you can see that, and then you can sign up if you don't mind having a late night. Scott, is it going to be recorded? Do you know?
Yes, it will be recorded. That's right, and it's about producing a local sort of toolkit for primary palliative care in your country. In this case, in Europe, we have a couple of people who've done that actually in Portugal and Greece. Actually, talk about that, and then. But that idea is something that the group was thinking about possibly for the future in Asia Pacific, maybe thinking even broader, according to what we've just been talking about.
Okay, yeah, no, that's
and Tanya is speaking at that as well, and I know that you're on the call just now, so that's great.
Yeah. Okay, so there we are. There's lots of great things coming up, and so do join in there if you can, and we'll arrange our next meeting probably around the end of June, beginning of July time, I think. And so, but do join in with the WhatsApp group, and we can keep on discussing. And thank you so much, everyone, for coming. Thank you to the Secretariat again for arranging it and doing all the technical aspects. Much appreciated.